Omaha and CSTE, I am humbled and honored to be standing here today speaking to you all and introducing our wonderful panel of speakers. I am Janet Hamilton with the Florida Department of Health. Do you want to introduce yourself?
I'm Brian. Too tall. I'm Brian Karras with Washington State Department of Health.
And this morning we will be moderating, or co-moderating, I should say, the session today. Before we begin, I wanted to mention that a few people have asked me, after reading the program agenda, that they have seen various subcommittee meetings or steering committee meetings, and the question that they've asked me is, I'm not currently a member of one of those committees, but could I still come to one of the meetings? And the answer is yes. Please join us. Please come. I speak on behalf of CSTE and the Executive Board in inviting you to those meetings. And please come not only at the conference meetings, but sign up and get involved. Much of CSTE's work, our work, is done during the subcommittee and steering committee meetings. We need you and we need your voice. We have three nationally renowned speakers this morning to set the stage for our second full day together. You will leave this conference and there will be something that sticks with you, something that inspires you, something that you take home that helps you answer a question or perhaps pose a better question. Maybe that nugget will be imparted on you this morning by one of our speakers. I hope you are feeling the epidemiology endorphins pumping through your veins. We look forward to a lively and stimulating discussion, the kind that inspires us as epidemiologists to do more of what we do. Come in, find a seat, and move to the front. I would like to turn it over to Dr. Karras to introduce our first speaker this morning.
Good morning, everyone. So, I'm Brian Karras. I'm the Chief Public Health Informatics Officer for Washington State Department of Health. And more than a decade ago, I came to the state of Washington, and one of the first things I heard when I landed at the University of Washington was a powerful presentation by the speaker you're about to hear. Dr. Stephen Bazarushka has been passionate about this for many, many years, and he comes to it with a wonderful background. You can see his history in the course or in the packet before you. Experiences from practicing medicine for 30 years to traveling and working in Nepal. But what I think is really driving and powerfully motivating about his current work is a presentation that he's put together talking about how the United States is doing in the Health Olympics. And a decade ago when I first saw the slide deck, we weren't doing so good. But the drive to get that gold medal, I'm sure in the past decade we're doing much better now, and I'm looking forward to hearing how we're doing in these Health Olympics.
Well, thank you very much, Brent, and thank you all for coming here. And unfortunately, I'm going to disappoint you. That is, we are falling behind. I titled my talk, "We're Playing the Game of Health Without a Scoreboard." So what do I mean? I mean that when we look at ourselves and try and see how well we're doing on measures of health, when the standard of comparison is other countries, the news isn't so good. How does this relate to the work that you do? Well, you may say, well, I'm deep down in the trenches, this doesn't matter to me. But I'm hoping that you will take some of these ideas to heart. What I want to do is something unconventional. I want to give you a quiz that I haven't prepared you for, and I want you to show of hands. Then I want to ask, why should we keep score? Why is our health status so poor? I want to suggest that inequality, the economic inequality we see, is literally killing us. And if we're going to do something about it, we have to address the first 1,000 days of our lives, something that is, I think, very in tune with what Dr. Anda thinks. And so, to you as applied epidemiologists, we need to make comparisons with the work we do with healthier nations. We need to inform the public, and we need to push policies. So here's my quiz. Question number 1. A 15-year-old girl in the United States has a smaller chance of dying before reaching age 60 than a similarly aged girl in Sri Lanka. How many think that's true, that the U.S. girl has a better chance of surviving to age 60? Raise your hands. About a third. How many think it's false? About the same number, and the rest of you are undecided. So this is a graph of the probability of dying if you're age 15 before reaching age 60. The demographers call it 45Q15 from 1970 to 2010. These are data from the Institute for Health Metrics and Evaluation published in The Lancet a while back. And you can see that in 1970, the US girl had a better chance, that is a lower probability of dying before reaching age 60 than the Sri Lankan girl. But around 2010, the curves crossed. So now, a girl from Sri Lanka, age 15, has a better chance of being alive at age 60 than a girl in the United States. Sri Lanka, I would remind you, is a very poor country. So for at least that indicator, our health status is that of a poor country. So the answer there is false. Second question. During the period 1987 to 2007, life expectancy for women in the United States declined in almost 30% of U.S. counties, something that wasn't true for the previous 20 years. How many of you think that life expectancy has declined absolutely in about 30% of U.S. counties? How many think that's false? Okay, so these are two maps of male and female life expectancy by county, again produced by the Institute for Health Metrics and Evaluation, where the red means absolute life expectancy declines over the period 1987 to 2007. Notice that there's much more red amongst the women and less amongst the men. The blue represent the longest life expectancy increases. Now, this was published in April of last year. It got about 1,000 media hits, but since then everyone's forgotten it. So the answer there is unfortunately true. I could show you maps for the previous 20 years. It wasn't happening then. Last question. Maternal mortality in the United States has increased 50% in the last 15 years. How many think that's true? How many think that's false? So these are the trends for just a few countries: Japan, Canada, Australia, Sweden, and the red being the United States. And you can see around 1995, the maternal mortality ratio started to rise. So the answer there is unfortunately true. So what's going on? Well, as Brent suggested, about 12 years ago, I thought to myself, I always thought, that this country was number one in just about everything. And then in the 1980s, I came to realize that our standing in measures of health compared to other countries was really nothing to brag about. And I became determined to study it and went back to public health school and have since been totally obsessed with these ideas. And so I coined the term the Health Olympics to suggest, we compete in Olympic events. The Olympics are coming up in London in the summer. If health were an Olympic event, if health were an Olympic event, how would we be? So I typically say, if we take life expectancy at birth, and I ask my audience, how many think we would get the gold medal? How many think we're in the top 5, top 10, top 20, top 30, and so on? I could do that exercise with you here, but I'll spare you the agony and show you the ranking of countries by life expectancy from the UN Human Development Report published last November. So this is the ranking of countries by life expectancy at birth, and there's the United States at 34th. Now, I use these data because it shows the United States in the best light. If you want to see something even worse, go to the Central Intelligence Agency's world rankings and dial in life expectancy, and you have to scroll down to 50th to find the United States. And it does so poorly in our CIA's ranking because they include a lot of tiny island economies and tax havens as countries, and I don't think that's fair. So when I went to medical school in 1970, we were 17th. When I went to public health school in 1992, we were 22nd. When Brent heard me talk, we were around 24th or 25th. And so unfortunately, our health, if the standard is comparing ourselves to other countries, keeps falling. If life expectancy at birth is a reasonable measure of health, and I think most people would conclude it is probably the best summary of measure, I think infant mortality is more sensitive to a lot of changes, but we've all passed infancy, and so it really doesn't seem to matter to us as much. So why? Why is the United States 34th? And what difference does almost 5 years mean? 5 life expectancy years mean in terms of the differences? Is it just another 5 years drooling in a nursing home? If you think of how you calculate life expectancy, you find that if we eradicated our leading killer today, cardiovascular disease, and kept the other disease death rates the same, we gain somewhere around 3.5 years of life expectancy. We still wouldn't be the healthiest country in the world. We spent almost half of the world's medical care bill, $2.6 trillion, 18% of our very gross national product, on medical care. So that can't be a big factor in our ranking. We think of personal behaviors. All of your public health work is related to personal issues. Out of all the countries on this list, the country with the lowest prevalence of men smoking happens to be the United States. The country with the highest prevalence of men smoking happens to be Japan. That is, of course, not the reason that Japan's so healthy, namely that everyone smokes there, at least all the men do. But it does suggest that there are factors much more important for producing health in a society that make smoking at such high rates, twice the rates in Japan as in the United States, not so important. That's what we have to consider. What are the population factors that affect health and populations that go beyond what we think of as the key determinants of health? I put Canada there in green, considerably healthier than the United States, because I want to make reference to the country later. Just to scale up the trends, this is published from the National Academy of Sciences 2 years ago. This is life expectancy at age 50. How many years women have left at age 50, and too many countries on the other graph to compare, so just 6 countries: United States, Italy, Japan, France, Austria, and Spain. And the heavy bar is the United States. And if you look over on the left-hand side at 1955, US women were the longest lived, meaning they had the most years of life to look forward to at age 50, and Japanese women had the least. Around 1980, there was a big inflection, and now you see how U.S. women, the red bar, shows how slowly health improvements are occurring among U.S. women in contrast to the other women. And that's pretty uniform. That is, a lot of changes in our health started happening when compared to other countries around 1980. And women have actually seen more of the brunt of decreasing good health outcomes in comparison to other countries. I talked about maternal mortality, so these are the maternal mortality Olympics. You can have Olympic events for just about any of the indicators that you measure. So this is a maternal mortality ratio in 2008, published in the Lancet, and the United States is tied for 39th. We're right there with Latvia and Macedonia and countries like that. I say this because I remember, I have a note page from my medical school class in 1971 saying that in 1951-53, the United States had the lowest maternal mortality ratio of all countries. Yes, we've improved since then, but many, many other countries do better than we do. This is the only U.S. government publication that highlights this, the Health United States, and this is the 2011 published earlier this year, which Table 20 lists infant mortality for selected countries and rankings. And so for the countries they have there, on the right-hand second column, in 1960, our ranking in infant mortality was 12th, and in 2008, our ranking was 27th. Much lower number in 1960 than in 2008 than in 1960, but other countries have done that much better. And at least our government highlights this. So how healthy are we doing? Unfortunately, not very well. So I suggest we're playing the game of health in this country without a scoreboard. This was the scoreboard, the first electronic scoreboard at Kaminsky Park. And that, I have to say, without a scoreboard, health is not a goal in this country. What are the desired endpoints? Well, our Declaration of Independence entitles us to life, liberty, and the pursuit. And I'm going to suggest that, yes, we're all in pursuit of happiness. The happiness indicators show about the same trends as health ones, namely, they are slowly declining, and the decline is biggest in women. So in many, many factors, we have to rethink what we're up to. So what's behind all this? Two things. One is poorer people have poorer health, and the second is early life is critical for health. So what do I mean by the first statement, poorer people have poorer health? Well, it's the socioeconomic gradient in health. It is the most pervasive finding that is there almost everywhere. So if you want to survive in the Titanic, if you had a first-class ticket, your chances were 60%. A second class, it was 40%. Third class, it was 25%. If you were a crew, it was 24%. So for almost anything we measure in life, being higher up the socioeconomic scale is better. To show this in the United States, these are your zip code is more important for your health than your genetic code. So this is a graph of age-adjusted mortality rates by zip code from the richest to the poorest, and there's a 50% greater mortality if you live in poor zip codes. So this book came out a couple of years ago by two British epidemiologists, Richard Wilkinson and Kate Pickett, The Spirit Level, that refers to a British carpenter's level, Why Greater Equality Makes Society Stronger. And what they did was create an index of all the things that we would like to do well in. These were Z-scores that they multiplied together of life expectancy, math and literacy scores, infant mortality, homicides, imprisonment, teenage births, trust, obesity, mental illness, and social mobility. And they graphed that against a uniform measure of income inequality among countries. And not unsurprisingly, we have the worst index of all these countries and the most income inequality. I think we have to say that inequality is literally killing us. The question is, how much is it killing us? Well, you know, you people have done such remarkable studies, we can answer all these questions. So a study from Harvard published in 2009 said if the United States had a Gini coefficient, that's a measure of income inequality, 0.3 or less, like the healthiest countries do, how many fewer deaths would there be in the United States? Based on a meta-analysis of multi-level studies. And what they found was about 880,000 fewer deaths would occur in the United States on a basis of all these studies if we had a Gini less than 0.3. That's roughly 1 death in 3. So if you take that perspective, you could say that 1 death in 3 is attributable to income inequality in the United States. It's hard to sell income inequality as being bad for us. You know, we've managed to do everything we can to create the biggest gap among rich countries in this country, and we seem to relish in it, though there are some efforts to try and do something about it. So how does inequality kill? Well, that's kind of debatable. There are several schools of thought. One is that there is a materialist perspective. In a smaller gap society, more people can buy the resources that you require to produce health, and that's certainly operating at some level. But at the other level, there is the psychosocial factors, namely how you feel about not being at the top of the hierarchy. And people lower down the hierarchy get put down by those above them, they put those down below them, and we live in a culture of chronic stress. And if you look at stress measures around the world, we in the United States have some of the highest measures, and so I side more with the psychosocial interpretation of that. So let's leave inequality and go on to early life. As you go from the erection to the resurrection, as you go from the womb to the tomb, the first 1,000 days from conception to age 2 is roughly when half of our health as adults is programmed. This is the developmental origins of health and disease paradigm. And the more I look at the research, the studies, the cohort studies, the impacts, it's really true. And another important factor is that health is transmitted intergenerationally. All of us in this room started life in our maternal grandmother's womb because the ovum that begat us, your mother made there. So that's just fathers matter too, but it's an easy way of conceptualizing how important your grandparents are for your health. And I think these studies would lead us to say that roughly half of our health as adults is programmed in this early period, and the paradigm suggests that most of the chronic diseases of aging happen because of adaptations made in this period. Early life and inequality. What are we going to do? We have to inform the public. What does that mean? Well, look at what healthier countries do. If you go to the Public Health Agency of Canada, they have it very quickly. You'll come to population health and what determines health. And in order, they rank the key determinants of health: income and social status, social support networks, education and literacy, and so on. Notice healthcare services is number 10, behind 9 other factors that they consider more important than healthcare services. That's really critical to understand. That is, do we want health or healthcare? All our focus in this country is on healthcare, and that's not going to get us health, because the provision of healthcare services, studies show, is a relatively minor determinant of our population's health, that the other factors are more important. So at least places in Canada are trying to get the word out. Most of us think that health and healthcare are synonymous. So I just want you to draw your attention to a town in northern Ontario, Sudbury, that is trying to inform its citizens. And so it has a YouTube video. Let's start a conversation about health and not talk about health care at all. And the key message in their video is this graph of poverty equals poor health. And that's the word that we have to get out to the American people, that their poor health status is not their fault. It's our fault for creating the society that does that. Alameda County in California has actually published material linking inequality to health, and they did a brown bag university on these ideas and the Occupy movement, which has been particularly strong there. We have to seed the Occupy movement with this understanding of inequality in health. So inform the public, make comparisons with healthier nations. You've got to do this and present it to policymakers. So I'm from Seattle, and here is a map of life expectancy for British Columbia, Washington, Idaho, and Oregon. And the darker brown colors are longer life expectancies, and you can see that the 49th parallel, the border, is a huge health divide. So those of you that border Canada, make comparisons with your Canadian neighbors and put that into your data and make presentations on that. Point out how our health status is. So the Institute for Health Metrics has county life expectancy maps, and this is one for Shelby County in Memphis, where I was last year. The red is lower life expectancy and the green is higher. And the interesting thing, if you go to the website, is they'll tell you countries that rank with Shelby County in the life expectancy Olympics. So Sri Lanka, Bosnia and Herzegovina, Guam, Lithuania, these are all countries with life expectancies comparable to Shelby County. People living in Memphis should know that. We got to level the playing field. How? Well, I think we need to increase government revenue, because we need the money to spend on things that produce health. And we can change corporate taxes, individual taxes, and we can raise the cap on Social Security. And all of you will say, well, this is not in my job description. It's in all of our job descriptions. This is the kind of medicine we need. If we don't do this kind of procedure, we're going to continue to die young. So in leveling the playing field, we have to turn to social spending, and we have to spend the money on early life. And what are examples of ways of doing that? Well, this is a map of, last month, UNICEF published a report measuring child poverty in rich countries. And only Romania has more child poverty measured as the percentage of children living in families with less than 50% less than the median income. So they also had a graph here about what do programs do through taxation and transfers to decrease child poverty. And in the United States, our child poverty rate was 25%, and our government programs and transfers reduced it only to 23%, whereas in Canada, with roughly the same child poverty rate before taxes and transfers, they almost halved it. So at the federal, state, and local level, we can do a tremendous amount to decrease child poverty just by the programs that are necessary. But countries have to decide to do that. What are we going to do with the money we make? We've got to support early life. And I think the two key policies that the research would suggest would give us the most bang for our buck are antenatal and postnatal paid leave, maternity leave. If you look at countries around the world, there are only 4 countries that do not grant paid maternity leave as a national policy. One is Swaziland, another is Liberia, a third is Papua New Guinea, and I'll leave you to decide who the 4th country is. We need to not be in that league. Finally, we need to highlight the socioeconomic gradient and focus on the income-health relationship. And I would suggest not looking at income inequality and poor health, because in your local levels, the strongest relationship will be between income and health. It will be a direct relationship. And so some of you are doing that. So Vermont, for example, published the Health Disparities of Vermonters 2010 report, and in there is a graph of smoking and income. And so, the poorer you are, the more you smoke. Smoking during pregnancy. If you aren't on WIC, you won't smoke, and if you're on WIC, you'll have more than 4 times the smoking rates. That's in a report for the people to know. This allows you to raise these kinds of questions of what's really going on in society. So I think we need to focus on primordial prevention, and primordial prevention is sort of to make things be so that good healthy things happen down at the end without depending on personal behaviors. And I think John Snow was the first real primordial preventionist when he thought there was something about the water in Broad Street pump, and he knew nothing about cholera. But what did he do? He got the city to remove the pump handle, and deaths declined. So we need to first make health a goal in this country, and health being a goal means comparing ourselves with other countries. And the desired endpoint would be a long and healthy life. It's not out of the realm to think of countries making a goal. Australia, number 3 in the Health Olympics, has set a goal, the government, to be the healthiest country by 2020. So keep tuned, let's see if they make it. It would not be a goal that we could attain unless we bombed about 35 countries ahead of us. At this point, I don't think we will. But we need a goal like that, the healthiest country by 2040 or 2050. It is, in a sense, our Sputnik moment. And this is an armored vehicle behind our hospital, and the key idea is there. The system is the solution. We have to create a system in this country that produces good health without depending on what individuals do for it. Thank you.
Thank you for depressing us all this morning. In the interest of time, we're going to move on to our next speaker and then have them answer questions as a panel when we're done. Our next speaker is a hometown boy. He grew up on a farm right here in Nebraska, and he's been. You can read his long list of accolades in the program, but I think the most important thing is that he's been the cornerstone of a bone mineral research group here in Nebraska, and I'm looking forward to hearing what he has to say. Dr. Robert Recker.
Thank you very much for that nice introduction, and thank you for the organizing committee to have invited me to this right here in my hometown. So I didn't have to travel very far, about 4 minutes from my office up the street here. And so I'm glad to be here, and welcome to all of you to our fair city. Okay, the title is Public Health Impact of Calcium and Vitamin D. What are we waiting for? And the scope of this will be, well, let me start by saying that I may have too many slides, so I'm going to have to go through them rapidly. I spent more time trying to remove slides than in putting slides in. So I'm going to talk about a history of vitamin D in health, measures of vitamin D status, clinical expression of D insufficiency, the new physiology of vitamin D, determining vitamin D need, how much is toxic, and what are we waiting for. The background includes the following. In the early 1900s, rickets was found to develop in dogs reared indoors and fed purified diets, preventable by cod liver oil. And in 1936, the active agent was identified as cholecalciferol, or vitamin D3. And the RDA for vitamin D was set at 400 international units because that was the quantity in 1 teaspoon of cod liver oil. So what we knew then was that vitamin D prevented rickets, the RDA was sufficient to afford protection, that vitamin D was necessary for calcium absorption, and how much vitamin D was needed was not known, that is, how much needed to optimize calcium absorption, and whether there was a connection between vitamin D status and any other disease. Also, we didn't know how one could tell whether a patient had sufficient vitamin D. And in its 1997 publication, the Food and Nutrition Board defined serum 25-hydroxyvitamin D as a functional indicator of vitamin D status, and that was a good decision on their part. The evidence then did not exist to allow tying any particular serum 25-hydroxy-D levels to specific health or disease outcomes. And the index disease for vitamin D deficiency was rickets and osteomalacia. The absence of rickets or osteomalacia, rickets is in kids, osteomalacia is in adults, in the skeleton, it was implicitly considered to be evidence of vitamin D insufficiency. And in setting the requirement, no other disease outcomes were considered. And the recent adequate intake recommendations, which have increased over the years a bit, are sufficient to prevent the index disease in most people. Now let's look at the vitamin 25-hydroxy-D continuum. This is a graph, horizontal graph, of the measurements we commonly get of serum 25-hydroxy-D in the serum of humans, ranging from 0 on the left to 150 on the right. And here comes the first problem. This is in nanomoles per liter, and this is the same thing expressed in nanograms per milliliter, and my colleagues are always complaining about which is which and why do you have to have 2? Why can't you have 1? And I haven't got the answer to that. And reference ranges were established by measuring a whole bunch of quote-unquote normal people. And also, I put on this slide the level at which prevention of rickets and osteomalacia occurs. And here are reference ranges found in people, just walking around out there. So what is the optimum level of serum 25-hydroxy-D? And a practical approach to looking at this is that increased serum parathyroid hormone levels is an indicator of homeostatic adaptation to this crippled calcium economy from vitamin D insufficiency. And the point at which the serum parathyroid hormone level bottoms out defines the point at which adaptation is no longer needed. And so look at a study here that's pretty old now, 1998, 290 consecutive patients on a general medical ward in the Mass General Hospital. And the y-axis is serum parathyroid hormone concentration in picograms per milliliter, and on the x-axis is the serum 25-hydroxyvitamin D levels. And you can see that the minimum PTH occurred at some level around 80 nanomoles per milliliter. Okay, how to determine normal? The relevant questions are, is the calcium economy optimal at 25-hydroxy-D levels below 80? And are the autocrine-paracrine functions of vitamin D optimal at 25-hydroxy-D levels below 80? And no for the first, and we don't know for the second. So let's take a look at some of the studies. On the bottom you see the continuum of serum 25-hydroxyvitamin D. We studied 34 women that, and these are the reference ranges that have been published, and we measured calcium absorption from a 500 milligram load, and we used the pharmacokinetic method. And the absorption fraction at the range of about 50 nanomoles per liter compared to about 80 nanomoles per liter showed that there was a 68% increase in absorption fraction with the vitamin D level in the reference range, within the reference normal range. Another study by Trivedi with the same, so I'm putting out here the same continuum and the reference range, and looked at fracture risk at lower versus higher levels, about 50 to about 75, and the risk of fracture. And in the higher levels within the reference range, there was a 33% reduction in fracture. So within the reference range, we see malabsorption of calcium and preventable fractures. And I might add that a hip fracture has a 25% mortality within the months following the fracture. And these are as much expressions of nutritional deficiency as the bleeding gums of scurvy. So, what is the prevalence of insufficiency using the 80 nanomole per liter figure? Well, Looker checked the NHANES data in women aged 60 to 79 in northern states in the summer. About 10% were below 40 nanomoles per liter, and 77% were below 80 nanomoles per liter. So, what causes this? Well, one thing that does is your skin sort of peters out as you age. Look here, Hollick did a study of the serum vitamin D3 concentrations in old people versus younger people with the same single body exposure of 1 minimal erythematous dose of UVB light. And you can see that the production of vitamin D in the circulation is markedly reduced in the old people. And here are data from surgically obtained skin samples in Caucasians, normals. And this is the measure of the 7-dehydrocholesterol in the skin with age. And 7-dehydrocholesterol is the precursor of vitamin D. And so when the UVB light hits the skin, 7-dehydrocholesterol is converted to vitamin D3. And look at that decline with age. There is a 50% decline in the concentration of 7-dehydrocholesterol from the age of about 20 to the age of about 80. So age is not kind to us in this regard either. So how much D do you have to give? Well, we did some studies. For example, this was a dosage study from October through February. And what we did was to give increasing doses. This is in micrograms per day, and this is in international units per day. And one of the things I want to really have you pay attention to is the top for the 10,000 units a day is about 200 nanomoles per liter. Okay? And this looks pretty predictable, too. It isn't reasonably predictable, but look at that curve. And you can see that if you describe that mathematically, you have an A value for the steady state. And so if you look at responses to oral loads and equilibrium concentrations plotted against the dose of D3, what you find is a formula describing this, which is listed there in the slide. And the R squared for that is about 75% of that variation is due to the dose. And if you take that exponent, or that term, 7 nanomoles per liter for every 1 microgram or 40 international units of vitamin D3, given as a daily dose. So you don't get very much out of 40 units or 200 or 400 units of vitamin D. Now, all recent studies have come into this range as 0.6 to 1.2 nanomoles per liter per microgram of D per day. And taking a figure in the middle of that range, 0.9, the recommended daily intake for individuals 50 to 70, which was in the past, 400 international units a day, would be expected to raise serum 25-hydroxy-D by only 9 nanomoles per liter, or 3.6 nanograms per liter. And the daily input from all sources required to maintain a level of 80 nanomoles is in the range of 3,500 to 5,500 international units per day. So, what about safety with these gigantic doses? Well, now, I want you to remember that the level of 200 nanomoles per liter in those given 10,000 units per day for 6 months. We looked at outdoor workers, 41% of body surface exposure for 38 hours a week for 14 weeks. That is today in this area. And what we found were 25-hydroxy-D levels in late summer, as you see, in an average about 125. But look, there are a couple of them that are above 200 nanomoles per liter. And they go down quite notably in late winter. But even in late summer, there are a few that are below what we think is the optimum level. And safety, look at the changes in serum calcium levels with these doses. 10,000, no hypercalcemia occurred. So in our experiments, doses of 5,000 to 10,000 international units a day in healthy adults for 4 to 5 months have not elevated serum calcium and have not elevated urine calcium. And further, these reproduce 25-hydroxy-D levels frequently found at the end of summer in outdoor workers, at which levels no hyperabsorption occurs, and we haven't seen any cases of vitamin D intoxication from too much sun exposure. So, what about the non-bone effects of vitamin D? Well, we've described up to this point the endocrine effects. That is, that vitamin D is converted to 25-hydroxy-D in the liver, circulates in the kidney tubules, 1-hydroxylate it, and the 1,25-dihydroxy-D is responsible for increasing calcium absorption and conserving calcium at the kidney. And however, this particular system uses up only about 1% of the vitamin D that you need for homeostasis. Now, I want to turn attention to the autocrine or paracrine system. This is altogether different. And the differences are, as you can see in this slide, the endocrine system is involved with calcium economy, that is calcium absorption and bone resorption. The autocrine system is involved with cell cycles, cell proliferation, differentiation, and apoptosis, and the immune response, importantly. And in the autocrine system, 25-hydroxy-D is 1-hydroxylated inside cells and then also degraded by 24-hydroxylation, and what reaches the circulation is inactive degradatory product of vitamin D, 1,24,25-trihydroxy vitamin D. However, in the endocrine system, the product is circulating 1,25-dihydroxy vitamin D, the active form. Now, there are about 1,000 genes now that have been described as having vitamin D response elements. Wow, it works all over the place. And what happens with this is transcription. And these transcription elements are controlling cell proliferation, differentiation, apoptosis, immune response, and of course the 25-hydroxylase, which degrades it. So, an example, innate immunity. Here we have an invading organism, let's say, which engages on the cell surface a toll-like receptor and activates it. That winds up in the nucleus of the cell, and that codes for production of cathelicidin. New thing. This is nature's broad-spectrum antibiotic, and it has nothing to do with antibodies. It is an antibiotic. And it's wonderful stuff. So let's get some more information about that. Innate immunity, I call this. Human monocytes have been cultured in fetal calf serum, and no cathelicidin. What gives? Well, you add 25-hydroxy-D to the system, and now you get cathelicidin, nicely produced. So how does this work in humans? Let's take a few examples. Vitamin D in tuberculosis. Here is a study of human monocytes activated with Mycobacterium tuberculosis, incubated in serum of African Americans, whites, and African Americans with added 25-hydroxy-D to the system. And this is a measure of cathelicidin messenger RNA, which is related to how it's produced. And what you find in the African Americans, if you give that a relative risk of 1, and whites, it's more than 2-fold, and in African American serum with 25-hydroxy-D added, you get a 3-fold increase. So here are human studies, patients with pulmonary TB, standard treatment for all, but randomized to either get 10,000 or units a day of vitamin D or placebo. And sputum conversion occurred in less than 80% of the placebo-treated patients, 100% of the 25 or the vitamin D-treated patients. And that probability is highly significant. And these experiments show that vitamin D is an essential mediator in innate immune response, and is a critical variable, is 25-hydroxy-D concentration. And at least some of the increased sensitivity to infection in vitamin D deficiency is due to reduction in response to infectious agents because 25-hydroxy-D is rate limiting. And the greater tuberculosis susceptibility of blacks could be well due to, in part, to their low vitamin D status. So the vitamin D autocrine-paracrine system functions in the tissue-level control of the immune response and of cell proliferation and differentiation. Let's look at the differences between the autocrine and endocrine systems. The endocrine system depends on renal 1-alpha hydroxylase, is regulated by parathyroid hormone, is largely independent of substrate concentration. However, the autocrine system, there's a tissue-level 1-alpha hydroxylase operates well below its Km. And hence, 125 synthesis is directly proportionate to the substrate serum 25-hydroxy-D, that's concentration, and thus adequate serum concentration of 25-hydroxy-D is critical for optimal function. So optimal endocrine and autocrine functions of 125-D are dependent on sufficient levels of 25-hydroxy-D. And the maintenance of normal serum levels of 25-hydroxy-D will reduce the risk of malignant transformation in tissues that use this system. So 125 inhibits genes responsible for proliferation, enhances genes that cause apoptosis, and regulates cellular differentiation. Let's look at mammary cancer. Low vitamin D status in rats increases mammary oncogenesis in response to a carcinogen, DMBA. And in mouse mammary gland cultures, 125 decreases the oncogenic response to DMBA. Let's look at some epidemiology. Breast cancer mortality. The mortality is in the y-axis, UVB exposure is on the x-axis, and you can see as early as the 70s, and published in 2002, there's a considerable linear regression of mortality, negative regression, mortality on UVB exposure. And this is solar radiation and cancer risk. This was as early as the 1930s. A decrease in the cancer mortality by solar radiation index. And so the maintenance of normal serum levels of 25-hydroxy-D will reduce the risk of malignant transformation in tissues that use this system. Let's look at some others. Prostate cancer. 13-year study, 19,000 men, 149 cases of prostate cancer. This is the quartiles, this is the relative risk and on the quartiles of 25-hydroxy-D levels. And that trend is highly statistically significant. In fact, those below the median 25-hydroxy-D were 70% more likely to develop prostate cancer than those above. Let's look at colorectal cancer from the Nurses' Health Study, 193 incident cases, 25-hydroxy-D measured twice prior to diagnosis. And here is the 25-hydroxy-D quintiles with odds ratios for colorectal cancer. And the numbers are the median values for 25-hydroxy-D, and that's a highly significant regression. And it looks like it takes at least 30 nanograms per milliliter to get the effect. It levels out at about the fourth and fifth quintiles. So we did a study of calcium and vitamin D supplementation in eastern Nebraska trying to demonstrate that we reduce the risk of cancer. Finished the study some years ago. And we also had in that, sort of on a whim early on when we planned the study, we'll count the cancers in this population as well. And so it was a 4-year study. Over 1,000 women finished. The baseline 25-hydroxy-D was pretty good. It was 71.8 nanomoles per liter on average. And we had 3 groups, a placebo group, a calcium-only group, and a calcium plus vitamin D group, and the D supplement was 1,100 international units per day. This is a plot of the fraction cancer-free over the course of the study. The difference between the placebo and the calcium and vitamin D group was highly significant with a relative risk of 0.4, meaning there was a 60% reduction in cancers. Okay, it was a secondary outcome variable, and it was interesting to me that when these data were presented at a meeting of the World Health Organization and a publication came out afterward, the article by my colleague Joan Lappy had about 3 pages, mostly filled with criticism because it was a secondary outcome variable and the population studied was small. I mean, I asked the question, well, how big is big enough? You know, there isn't any statistic. But, well, anyway, that aside, so solar radiation and cancer mortality and the inverse correlation between cancer death rates and sunlight exposure is found for numerous cancers. There's a whole list of them there. On diabetes, look at this plot, which on the x-axis contains degrees north or south latitude, in other words, distance from the equator, and these are reporting countries, and the data are obtained from World Health Organization. You can see a nice U-shaped curve with increasing incidence of diabetes in children the further you get from the equator. Same thing is true for multiple sclerosis. Well, when is this going to end? Highly significant, 46% of the variation was due to latitude. So what are the diseases and conditions with evidence supporting a link to vitamin D insufficiency? Well, look at them. Falls, fractures, diabetes, multiple sclerosis, autoimmune disease, infectious disease, all types of cancer, cardiovascular disease, hypertension, myocardial infarction, asthma. So vitamin D serves many functions beyond facilitation of active calcium absorption, and the absence of rickets and osteomalacia does not constitute vitamin D sufficiency. The calcium-related functions are optimal at or above serum 25-hydroxy-D levels of 80 nanomoles per liter, and those who have a laboratory that reports in nanograms per milliliter, that's about 32 nanograms per milliliter. And optimal values for 25D are the non-bone effects, for the non-bone effects are not known. And the RDA and DRI for vitamin D ensures only absence of rickets and osteomalacia. Individuals who are dark-skinned, elderly, or living at high latitudes need more than the RDA for bone health. So implications are if 80 nanomoles per liter is accepted as the lower limit of healthy normal for 25-hydroxy-D, even above average summer sun exposure at 41 degrees north latitude, which is where you are right now, is not sufficient to guarantee winter-long sufficiency or to ensure even summer sufficiency in dark-skinned individuals. So conclusions are most of the vitamin D consumed each day in healthy adults, that is by your body, comes from the skin. And optimal levels are above 80 nanomoles per liter. And persons with 25-hydroxy-D values lower than optimal have inadequate skin input. And if we are to rectify this situation, we'll need to use oral D doses substantially higher than current Food and Nutrition Board and Institute of Medicine recommendations. So what are we waiting for? Well, the foregoing, and I had a discussion with some of my colleagues about this fact, and you'll see what I'm getting at here. The foregoing presentation contained mostly epidemiologic and basic research. We need confirmation with clinical trial data to convince scientists and policymakers. Vitamin D deficiency resembles nutritional deficiency in general. The result is very long latency disease. The disease phenotypes appear only after very long periods of time have elapsed. And randomized clinical trials are impractical because of the time and expense required to accomplish them. So what options might we consider? Okay, we could try to convince scientists and policymakers that bench science and epidemiologic associations are enough to make a public health decision in this area. This may be impossible because of widespread scientific skepticism and safety questions that can only be answered by randomized controlled trials. And two, we might consider conducting a few randomized controlled trials in some disease category that may be doable and practical. Like, for example, we now have enrolled 2,300 people randomly selected from Nebraska into a randomized placebo-controlled trial in eastern Nebraska, testing whether calcium supplements of 1,250 milligrams per day combined with 2,000 international units a day of calciferol will reduce the incidence of all cancers over a period of 4 years. And I'll have to really eat crow if it doesn't work. Anyway, thank you very much for your attention.
Thank you, Dr. Recker. Our closing speaker this morning is Dr. Robert Anda, who is the co-principal investigator of the Adverse Childhood Experiences Study, or ACE study. When I was talking to him before we got started this morning, he also mentioned when I asked him if there was anything interesting to pass along to the group, and we all have our wannabes, and he mentioned that he was a wannabe neurobiologist. Dr. Robert Anda is a senior researcher in preventive medicine and epidemiology at the Centers for Disease Control and Prevention. He is the principal investigator of the Adverse Childhood Experiences, or ACE study, which examines the health and social effects of adverse childhood experiences over a lifespan. He has spent over 20 years in the U.S. Public Health Service at CDC, conducting research in a variety of areas, including disease surveillance, behavioral health, mental health and mental disease, cardiovascular disease investigations, and childhood determinants of health. Like many of our speakers this morning, he has many peer-reviewed publications. He has also authored several book chapters, as well as received numerous scientific awards. We have all heard about the ACE study, and we are eager to learn more about the journey of human development together this morning. We often say in conversations that having children changes everything. These issues impact all of us. I am so pleased to welcome Dr. Robert Anda to the podium.
Thank you. Good morning, everyone. It's really an exciting time in this field. Developmental neurobiology is really expanding rapidly. The understanding of sequential brain development is an area that's really very interesting and very exciting. And the effects of the biologic effects, the biochemistry of stress has a profound effect on childhood development. And as I talk today about adversity, I will be showing you where neurobiology and epidemiology and public health converge. This has been a journey for me over the past 15 years of having to learn about this. My training in medicine, internal medicine, my experience at the CDC as a cardiovascular disease epidemiologist did not prepare me for this. So I've had to learn on the fly. And I hope after the next few minutes of my presentation that you'll have an interest in neurobiology and the life course model, the life course pathways by which adversity influences public health. And I encourage you to go to the CDC website, which is listed here, where you can learn a lot more about the many publications that we have from the Adverse Childhood Experiences study. This is one of my favorite photographs. It's called the Walk to Paradise Garden. And I like to use it because it reminds me how naive that I was before I got involved in this work. I thought that most children had this beautiful walk to paradise garden with a bright future. And as I got into studying child abuse and neglect and domestic violence and the kind of stressors that affect their life course pathways, I saw behind them this darkness, the dark shadows behind them. And we don't know what children experience unless we measure the types of experiences that children have in our culture. And so this is what we did in the Adverse Childhood Experiences study, is to see how adversity influences the pathways that these children go on. And the impact of adversity on life course pathways is really, in many instances, very highly predictable, which gives us a tremendous opportunity for primary prevention. Much of the information that you're going to see in the next few minutes is sort of dark and can be kind of depressing. And I don't want you to be depressed by this information. As a researcher and person involved in prevention, I see the opportunity for prevention, enormous opportunities for prevention in this information. So when I talk about adversity, I'm talking about stress. And we all know about the stress response, the release of adrenaline and cortisol from our adrenal glands. Adrenaline is a neurotransmitter substance, and our neurons talk to each other through neurotransmitters in the gaps. Cortisol is a steroid hormone that's released from the adrenal glands. And cortisol is good for us in terms of the stress response, but if it's overactive, in animal studies, cortisol inhibits the ability of neurons to make healthy connections. And in high doses, cortisol kills nerve cells. So an overactivated stress response can have a really negative impact on neuronal networking and on brain development. If the stress is unpredictable or severe, it leads to vulnerability. If it's predictable or moderate, it leads to resilience. And by resilience, I mean the ability to be in stressful situations, learn from them, and bounce back and not be biologically overwhelmed. Some of the factors here in the white font on this slide that determine where we end up on this continuum between vulnerability and resilience, and it is a continuum, I think, for all of us, are the number of times we get stressed, whether it's chronic over time, over weeks or months or years. There are genetic factors that are involved in the stress response. The field of epigenetics is a very exciting field that tells us that these kind of stressful experiences can modulate the reading of the human genome through the attachment of substances to the various genes. And in animal studies, the epigenetic mechanisms work through maternal parenting behavior. And of course, intrauterine exposures have a great effect on the continuum between vulnerability and resilience. This slide is from the Center on the Developing Child at Harvard University, and it's titled Persistent Stress Changes Brain Architecture. On the top, you see the normal cell, beautiful cell with lots of colors and connections circled there. On the bottom panel, under conditions of toxic stress, you see a neuron that's not as pretty and is not as healthy. On the right, on the top, you see the axon with the many healthy connections. This axon is reaching out to make networks with other nerve cells. There's a lot of reaching and branching out. And below, you see the damage that's done by the biochemistry of stress. There are many fewer, maybe half as many attempts of this neuron to connect with other neurons. So this is an example of probably of the effect of cortisol on the ability of neurons to network. I show you this. It's difficult to look at, but you see this young child at a dinner table who looks like he's about maybe 3 years old, and his parents are terrorizing him. And so he's in fight or flight. And we know that neurodevelopment is sequential. This little boy is probably at a time where he is getting ready to learn how to read and write. He's learning how to regulate his affect. He's learning what relationships are like and how to relate to other people. And so what these parents are doing that people don't understand, and this is, I believe, is part of the public education part of this, is these parents don't understand that they're doing something that can have a lifelong biologic impact on the way this boy functions. And the other part of this that I want you to think about is, how did those parents get to the point where they can't regulate their affect and where they can't regulate their behavior with their child? The prevention in this field is highly dependent on disrupting the intergenerational transmission of toxic stress from person to person. Here's 3 panels of brain cells. The first one is at birth. There's about a dozen cells there. And in mammals, and especially in our species, Homo sapiens, we come in largely unwired. Most of the networking that we have develops after birth. So you see that there's not many connections at birth. By age 6, with the same number of cells, there's hundreds or thousands of connections between these cells in this part of the brain. The making of these connections is experience dependent. The quality and quantity and robustness of connections in our brain is dependent upon the input from our sensory systems. And go to the panel on the right at age 14, at puberty, you see fewer nerve connections there. There's a process that occurs at about the age of puberty called pruning, whereby the least experienced sets of connections tend to withdraw. The best explanation I've heard for this is that if we haven't had certain types of experiences by about the age of puberty, we're probably not going to have them. And this may be sort of an efficiency thing in the brain so that we don't have excess connections that we don't need to move on in life. So there's this branching you see at age 6 and the process of pruning of the least experienced neural networks. Here are 2 scans. On the left is one child, on the right is another. The circled areas on these brain scans are the frontotemporal region of the brain. The frontotemporal region of the brain has a lot to do with human relationships, with facial recognition, attachment, the quality of the ability to have quality social functioning and families and working with other people and adjusting to other people's behavior. The child on the left, you see the high red dense activity there. This child has had the stimulation from caregivers, the social stimulation and attachment that was necessary for healthy functioning in that part of his or her brain. Contrast that with the child on the right, where you see there's very little activity in the frontotemporal region of the brain. The child on the right was raised in a Romanian orphanage, where there were very few caregivers, and the children were severely emotionally and socially neglected because there weren't enough people to interact with them. And so this is neglect. This is the lack of neural networking that occurs from not getting the stimulation necessary to create those neural networks. So we have the abuse with the high toxic stress, fewer networks, and the neglect, which is not getting the stimulation you need to get the neural networking in place. So I'm going to be talking about adverse childhood experiences. This is what we call the ACE pyramid. And it uses a life course model from conception to death. You see the arrow on the left, from conception to death. So in the pyramid, time in life is going from the bottom to the top. And in my work, the first 20 years at the CDC, I worked in the top half of the pyramid. Working on identifying risk factors for disease, disability, and social problems, with the idea of preventing those and preventing early death. And to be honest with you, I got really frustrated because I think that these things are good things to do, but often they don't work very well and they're expensive. And so what we did in this study is we hypothesized that adverse childhood experiences disrupt neurodevelopment, leading to social, emotional, and cognitive impairments through the developmental neurobiologic pathways that might help to explain why some people have many risk factors for disease and disability. And if that's the case, then we have tremendous leverage for primary prevention and public health. The ACE study examines the health and social effects of adverse childhood experiences throughout the lifespan in more than 17,000 members of the Kaiser Health Plan in San Diego County. Just a little bit about this cohort of people, these 17,000 people. They were interviewed and surveyed in a primary care setting. These were not people who were sick. They were coming in for wellness care, for health appraisals. It's a highly educated group of people. Most have been to college. Only 6% don't have a high school diploma or a GED. It's a middle-class community. If you've been to San Diego, you'd see it's mostly a middle-class, upper middle-class community. And the cohort is predominantly Caucasian. The first thing that we saw in studying these people in the Kaiser Health Plan is that adverse childhood experiences are common. And before you look at the percentages here, I just want to walk you through what we mean by adverse childhood experiences. In the white font are 10 categories of stressful experience. The first heading is household dysfunction. That is growing up as a child with people, substance abusing caregivers or substance abusing people in your household, parental separation or divorce, having mentally ill caregivers, witnessing domestic violence, which we label as having a battered mother, physical violence against your mother, criminal behavior, as evidenced by having someone in your household incarcerated when you're growing up. There were 3 forms of abuse studied: psychological, physical, and sexual, and 2 forms of neglect, emotional and physical. And as a cardiovascular disease epidemiologist, seeing this data for the first time, I was stunned, especially given the socio-demographic group that we're studying. I wept. I was the first person to see the data. And I didn't know this. 27% grew up with substance abuse, 1 in 4 with parental discord, which is a stressor for children, 17% with mentally ill caregivers, 13% said they witnessed domestic violence, 6% had someone in their home sent to prison, 11% were psychologically abused, 28% had been physically abused, and 1 in 5 had been sexually abused. 15% were emotionally, and 10% were physically neglected. So ACEs are common. First point, ACEs are common, even in this demographic group. The next thing that we saw, because we studied these multiple categories of adversity, is that where there is one type of adversity, there tend to be others in the life of a child. So they rarely occur in isolation. They tend to come in groups in the life of a child. And let me help you think about this. So ACEs tend to come in groups. So imagine if you were one of the 17,000 people in this study cohort. If you were one of those 17,000 people, and you reported to us that growing up, you witnessed domestic violence, that you witnessed your mother being physically abused. If you were one of those people, your probability of having additional categories of adversity are in this table. So the probability of having one additional category is 95%. So it's almost universal where there is domestic violence in the life of a child. There are other categories of adversity, other stressors. And if you go to the far right on this table, to 5 or more, half of you, 52% of you, would have 5 or more of those other 10 categories of adversity that we measured. So that would give you 6 or more. And you think about the biology of stress, that's 6 or more different types of stressors that can affect your developmental trajectory. So what we did to respond to this is we just created a score. There were 10 categories of adversity. We counted each category of exposure 1 point to create an ordinal scale. It's not weighted. Each one an integer count of 1 for each category of adversity, and created this adverse childhood experience score, which I now consider a tool for measuring the cumulative biologic stress dose that these people had growing up during childhood. And so here you see the ACE scores. When we added these up for the people in the Kaiser Health Plan, only 1 in 3 had an ACE score of 0, had none of those childhood experiences growing up. 26% had 1, 16% had 2, 10% had 3, and 16% had 4 or more. So we have ACEs are common, they're highly interrelated. We create a scoring system, which we believe is a cumulative marker of biologic stress dose. And then started looking at how this scoring system related to a wide variety of public health issues. So in this set of graphs that I'm going to be showing you, we look at the ACE score, see going from left to right. Look at the first set of bars, which is the percentage of people who became regular cigarette smokers by age 12. And going from left to right, you see ACE score 0, 1, 2, 3, or 4 or more, and you see this stepwise graded relationship. The probability of becoming a regular cigarette smoker goes up 3 or 4-fold as you go from ACE score 0 to ACE score 4 or more. Go to the next set of bars, current smoking, here average age 55. You see the same dose-dependent relationship between smoking and the ACE score. And on the far right, you see the percentage of people in the cohort that have chronic obstructive pulmonary disease, chronic bronchitis or emphysema. And so this is the ACE pyramid model. Adversity leads to the adoption of health risk behaviors, which sustained lead to disease, disability, and social problems. And just by way of quick explanation, we believe the explanation for the smoking is that adversity messes with the development of the limbic system, the emotional control systems. So people that have high levels of adversity in childhood tend to have more anxiety and more depression and have more difficulty thinking more clearly and with their executive function. And nicotine helps with all of those things. So many of the behaviors that we see here that people kind of get blamed for are actually a natural biologic adaptation to the effects of the adversity on the way their brain functions. Here we have the ACE score and risk factors for HIV. On the far left is ever shooting up drugs with a needle and syringe. And I'll point out, for ACE score 0, there's this little slice of green there. I had to fake that on the PowerPoint because if you look at the printout, there's 5,000 people represented in that little bar there. There's almost nobody who ever took a needle and syringe and shot up. So in the absence of these kind of stressors, it's hard to find people that will shoot up. In the center set is sexuality. Sexuality and sexual behavior are affected by adversity. That's having 50 or more lifetime intercourse partners, goes up with the ACE score. And on the far right is the percentage of people in the cohort who ever had a sexually transmitted disease. And so these are the pathways to sexually transmitted diseases: alcohol, drug abuse, and having a lot of intercourse partners. Alcohol. On the left is the percentage of people who are self-reported alcoholics. Goes from about 2 or 3% to 20%. So you see 6 or 7-fold increase in the risk of alcoholism. And it affects, we talked about attachment and relationships. It affects the type of relationships people get into. So on the far right is the percentage of people who said they ever married an alcoholic based upon their childhood experience. See the same thing for marriage to drug abusers, marriage to people who are violent or sexually assaultive. What about mental health? Here we have the ACE score and a lifetime history of major depression, the leading cause of disability in developed countries. ACE score is going from left to right here across the x-axis. And let's take a look at the data for women. As the ACE score goes from 0 to 4 or more, you see a lifetime history of depression going from 15% to 60%. Women, when they score 4 or more, have a 60% probability of having a lifetime history of major depression. And the pattern is similar for men. Here we have suicide attempts. Suicide attempts are uncommon in people with an ACE score of 0 and rise up to 1 in 5 for an ACE score of 4 or more. And so you see, when you look at the odds ratios for these, you see odds ratios for many of these things as the score goes up. It's dose response. You see odds ratios of 6, 7, 8, 20, 30, 40 for some of these major things. You almost never see these kind of graphs over and over. I have hundreds of graphs that show this dose-dependent relationship between adversity and public health outcomes. And I think what we stumbled into is this biologic stress dose and its effect on our central processing system and all the ways it functions and interacts. ACEs are related to many of the leading causes of death in the United States. This particular one example that I'm showing you is the ACE score and the prevalence of coronary heart disease in women. As you go to the right, far right, ACE scores of 3 or 4, you see a doubling of the prevalence of coronary heart disease. Some of this is mediated by traditional risk factors for cardiovascular disease, and some of it is mediated by things that we don't understand. Probably differences in endothelial cell function, which is being studied in stress. The immune response is elevated in people exposed to stress during childhood, and cardiovascular disease has an inflammatory component. So some of the biologic pathways are going to be figured out over the next 5 or 10 years by which ACEs lead to disease pathways. So adverse childhood experiences, I believe, are, in my opinion, based upon the data, are the most important national health issue in terms of preventability. And if you go to the CDC website, you can go and click on each of these things. These are all published in the biomedical literature. ACEs have a graded relationship to issues in adolescent health, reproductive health, smoking, alcohol abuse, illicit drug use, sexual behaviors, mental health, the risk of re-victimization later on in adult life, of being assaulted, sexually assaulted, or being a victim of domestic violence. It affects the stability of relationships, the ability of people to maintain their marriages, and it affects the ability of people to do their work on the job, which has, I think, an impact on the corporate bottom line. ACEs increase the risk of dying young. People with an ACE score in the follow-up part of this study, in the National Death Index, when they score 6 or more, on average die 20 years younger than people with low ACE scores. It leads to heart disease, lung cancer, chronic lung disease, suicide, injuries, HIV and STDs, and autoimmune diseases like rheumatoid arthritis, lupus, and other autoimmune diseases. And I want to let you know that beginning in 2009, we prepared a set of questions about childhood diversity for inclusion in the behavioral risk factor surveillance system. So in 2009, these states, 6 states, included that in their behavioral risk factor surveillance system. And here you see we were kind of surprised at the level of interest in this, given how early we are in really describing the epidemiology of this. Here is 13 in 2011. And in 2012, the one state that I know of is Iowa. There may be others that I don't know of that are including this in their surveys. All right, so I don't know where you are. The CDC does not have funding to supplement this. Now, the state when I travel around, I encourage people in the state health departments to go to foundations or to gather funds from other departments. And most of the states in the last couple of years that have done this have gotten money from foundations or by piecemeal getting funding from across their different departments or divisions. So I'm going to end with a little story. I like to use art. Those of you who don't know Greek mythology, this is the depiction of one of the labors of Hercules. Hercules wanted to live on Mount Olympus. His father was Zeus, the king of the gods, and he was half mortal, half god. And they gave him 12 tasks. They gave him 12 tasks to do to earn his way to Mount Olympus. One of those is to slay the Hydra. The Hydra was a mythical beast that you see in the center of this, with a many-headed beast that spewed sulfurous fumes from its body, or from its mouth. And Hercules, being the brave hero that he was, strode into the woods and began to hack away at the heads on this Hydra. And in my mind, in the metaphor of this, the Hydra has innumerable heads. And so in order to get in and start slaying this thing, he had to go one head at a time just to survive. And so he started slashing with his sword. And you can see on the forest floor, some of the heads are being cut off. They're on the forest floor. But he's in so close doing this one head at a time thing that he didn't see what this mortal on the right came in to see how he was doing, saw that at the end of on the neck, after he cut off a head, 2 heads grew back on the stump. And Hercules didn't see this because he was so busy just trying to survive. And this guy that came in, I think it was his cousin, said, Hercules, you got a problem. This one head at a time thing is really making things worse. Okay? And so what he discovered is that if Hercules cut off a head and he took his torch and cauterized the neck, that was done. Okay, that head was slain, so nothing grew back. And so by this cooperation between Hercules and the guy with the torch, he was able to cut off all these heads and survive and slay the Hydra. And I think if there's nothing else that you take away from what I've talked about today, or maybe even from this meeting, is that this is the first mythologically documented instance of interagency collaboration in the history of mankind. Okay? Now, that's the punchline. We laugh because we know how difficult that is. But if in this metaphor, if you look at this Hydra, I showed you a few and a list of all the many things that adversity leads to in terms of public health and social problems. And to me, this Hydra beast, the body is the embodiment of toxic stress and the way it affects developmental neurobiology in so many ways. And the heads are all the many manifestations in public health in our society of the kind of problems that we have. And from a systems perspective, We have built systems to treat the heads one head at a time. We have mental health and substance abuse. We have criminal justice. We have an education system. We have all these many systems that now, I believe, are beginning to take this information in and to begin to understand that the neurobiologic pathways that lead to one set of problems in one siloed system have a commonality with other parts and other siloed systems. And what I'm seeing as I travel around the country and do these kind of presentations and meet with stakeholders, we have stakeholder meetings after these presentations, I see people from all the various systems now beginning to say the difference is about 5 years ago they said they didn't believe this information. Now they believe it because the science is getting better. Now what they're saying is, okay, now how do we share this information and how we can work together? So I'm really optimistic that there's systems change that's going to happen to deal with the effects of traumatic stress and to begin to drill down and prevent childhood adversity, which I think is the greatest opportunity for prevention that's ever been seen in the history of mankind. So thank you for coming today, and thank you for taking your time this morning.
A few minutes. All right. Well, I'd like to jump right to opening up to questions. A few minutes. Please make your way to the microphones.
Hi. Being an epidemiologist, I've been thinking a lot over the last 3 days.
That's dangerous.
Exactly. You know, I went to a community health assessment session on Sunday, and then the plenary yesterday kind of fell into some of that. And even the discussions today, especially with the most recent talk. Thank you very much. You know, I'm married to someone that works for a bank. So economy often comes up in the conversations at home. And we like to think we balance each other out with that. But I think we as epidemiologists, we as health professionals, physicians, hospitals, we're talking to each other, we're preaching to the choir. And we can identify these different risk factors in different pockets of populations. But given the fact that we are living in a community that has had a stressed economy, we're starting to see people go two different directions, come together as a community, hold on to everything for themselves. And you're seeing that play in politics as well. Until we bring to the table the business leaders and the decision makers and bring this conversation back to how does health and education affect economy, we're only going to be able to make as much improvement as we can with each other within the health system. And I think a mechanism to get those individuals to the table and explain, when you have an educated population, when you have a healthy population, you'll have a healthy economy. I think we need to make sure we don't leave that word out of the conversation and tie that back. And I haven't heard that over the last couple of days. And so I think the community health assessment, even with all of its nuances and imperfections right now, is a great mechanism for epidemiologists to be part of that conversation and help drive that home. Because otherwise all we're doing is we're marginalizing populations. We're saying Americans might have a tendency to say it's that other group, it's that group, and especially since we're so good at finding risk factors, we have to be careful not to also create a culture of, well, it's your fault because you did this and you haven't done this. So I just would like to bring that into the thought process.
Thank you.
We'll go ahead and take our next question.
Hi, Megan Davies, North Carolina. So that last lecture was kind of like the unifying theory lecture of the conference so far for me, because we started the plenary sessions yesterday with discussions of inequities in society, and then the first session this morning about where we rank in the world and economies and investment in society, and then it got narrowed down to neurobiology and the first 3 years of life, including from starting at preconception. So I figure my grandmother should have moved to Canada. And I would have a great life expectancy right now. But in all seriousness, as a state epidemiologist, and when we go to the table with partners in the community with this information, they're going to want to know what to do. And we need evidence-based programs that have been shown to have impact in that critical time period. And I'd like to know about resources for that beyond the community guide. Are there ones that haven't been as firmly proven as that we could get started with?
Yeah, that's a really good question, and I'm going to start by saying one of my beliefs. I think the disparities research is really powerful. I believe that these pathways that I described are pathways to disparities, that some of the underlying biology of disparities lies in pathways to poverty. One of my beliefs is that the people who are exposed to childhood adversity, who develop mental health and substance abuse and drug problems and difficulties with social relationships are the people who tend not to do well in school. And there are other studies, documenting that they don't do well in school. They have lower grade point averages. They tend to be suspended or expelled more from school. They have substance abuse problems. They're more likely to have teen pregnancies. And then guess what? They end up in the juvenile justice system. I was just in Florida talking to the Louisiana Bar Association and Judges Association, talking to them about how their justice system has become a de facto mental health and substance abuse treatment system, and they're not set up to do that. So I think some of the disparity stuff ties in with this developmental neurobiology and human functioning. And in terms of what to do, there are places, there are states, I know the state of Washington and the state of Massachusetts are now teaching the kind of material that I presented this morning in the public school systems, and they're developing what they call trauma-informed schools, because this shows up in the classrooms. The disabilities related to adversity show up in the classrooms, and by responding differently to students, they can be kept in school, they're more likely to succeed. And in a recent study that went viral on the internet in Walla Walla, Washington, where they've used this information at a community level, they reduced suspensions and expulsions by 85%. And the juvenile justice systems can also use this information to try to find referral patterns for trauma-related substance abuse, behavioral, and mental health problems. So I would encourage you to begin to work with your Department of Education and your justice system, especially the juvenile justice system, the foster care systems, to begin to understand the trauma histories of the children that are in those systems, so that you can do trauma-informed treatments. And also the people that interact with these kids need to understand their own history, because what happens is people's own personal history can flare up and get in the way of the interactions with these kids. So those are two concrete suggestions that I have that are being used in other states.
Actually, well,
I was just going to say, I think we have time for one more question.
okay. Well, actually, this one's for Rob, so I don't know if you want to stay at the microphone, Rob. But first of all, excellent presentation. All the presentations were excellent. My question, Rob, kind of picks up a little bit on what Megan was just talking about, the intervention side of the equation. You were just speaking to that a little bit, but if we go upstream and think again from a primary prevention standpoint, a couple things strike me from your presentation. The obvious, of course, is the need to do a better job with child abuse prevention writ large. And I'm interested if you could comment a little bit on what we know about what works in the area of child abuse prevention. But the other thing that really jumps out for me is, while clearly you were able to show the graded response, and I'm going to focus particularly on smoking, even though I work in the alcohol area, it was interesting that in the ACE study, which was done, as you said, in San Diego, even among those who had ACE scores of 0 to 3 or so, the prevalence of smoking, if I was reading your slide correctly, was in the range of 6 to 12%, which is on the order of something a little bit more than half of what we have in the United States as a whole for adults. And so I guess where I'm going with this is, in terms of prevention here, it seems like there's individual level prevention, what we can do in the home environment to mitigate the risk of adverse childhood experiences. But then that also, of course, interacts with the broader environment. And I wonder if you could talk about the extent to which some of the broader environmental policy measures that we know work and have worked very well, for example, with smoking, and in the state of California is a good example, might mitigate the effect of some of the traumas that are occurring in the home environment. So sort of a two-pronged question there.
Thank you very much. And I will just paraphrase that I think the question that we're posing here is what are some of those broader environmental policy areas that we can look at that could have impacts on these childhood adverse event experiences?
Some of these things are my personal beliefs because the data are not there yet. One of my beliefs is that everybody should know this information. People that I talk to, audiences that I talk to, tell me that when they get this information, it helps them to understand their lives. It changes parenting practices. It changed my personal parenting practices. I think that there are prevention opportunities in things like nurse home visitation. Nurse home visitation programs teach parenting and reduce the incidence of child abuse and neglect. And I think that the institutions that interact with kids need to look at their policies. And the two that I mentioned that I think they're most promising, where there's data beginning to come out, are in the public school systems and in the juvenile justice systems. By understanding why the behaviors and why the problems are there and responding to them differently and not making things worse. I think our school systems and our justice systems tend to make these trauma worse and bump these kids into pathways that are the pathways to low-wage jobs, to poor health, to poverty, to lack of health insurance, and to homelessness. So I know you tend to ask really big questions, Bob. That's what I like about you. And my answer is relatively limited. I think we're at a stage now. I tend to think of this field and the biology of this field as where the prevention of cardiovascular disease was in 1960. So we're at the time where the science is built up, we're documenting the problems, and now we need to invest in treatments and prevention and policy changes to see whether or not we can change the prevalence of adversity or whether we can reduce the morbidity that's involved with adversity at a population scale.
Okay. Thanks.
If I can just chime in, I think the key policies that we need to push for are policies that give you time to parent, give you time to be pregnant. There are 5 states that have a minimal antenatal leave policy. States are, a maternal leave policy. My state, Washington, passed one in 2009, but it was contingent on a tax increase, and that fell by the wayside. So I think the key policies are to have time to parent, and you need money to stay home to be able to do that. So I would push for paid antenatal and parenting policies.
So I would like to thank all of you for attending this morning's session. I hope we can give a nice round of applause to our speakers. I think they have each given us something to think about, a call to action. So enjoy the rest of your day and get some sunshine, get that vitamin D, and thank you all.